It's not being recorded. So yeah, so the INR of 2 to 3, as Asman has said, is actually what is the normal, considered to be the normal INR values. Okay, so Tour is asking, is it a must for warfarin to be given with heparin, or can it be given alone? So, okay, you usually think it is recommended that you give them both, because usually heparin is usually given, I think, by injection, which is not usually suitable for a lot of patients, the majority of them. So since warfarin is an oral drug, it's actually recommended to give warfarin for better adherence. But as we know, warfarin usually has lapse or delay for onset of action. It usually takes about 2 to 5 days for the anti-clotting activity of it to be visible. To be observed, sorry. So for that reason, we'll have to give heparin first, and then you can add, you give heparin, then warfarin. Then once warfarin kicks in, then I think you can stop the heparin. Yeah, so for mode of action, I think we've tackled it. Inhibition of vitamin K epoxide reductase, and what factors will be affected? Just the last thing as we go to the next question. Which factors are going to be inhibited by warfarin? Yeah, 2, 7, 9, and 10. Thank you. Okay, so for the next question, the following are correct about diabetes mellitus, except, so glycated hemoglobin is an indicator of glycemic control. An adverse effect of metformin is weight gain. Both type 1 and type 2 diabetes have genetic predisposition. Sulfonylureas act by enhancing insulin production. Which of the following is not true? Yeah, today guys don't have voices or something. I'm usually used to ladies leading something. Okay, so by elimination, B is actually the correct answer. Sulfonylureas act by enhancing insulin production. We know that is true. Both type 1 and type 2 diabetes have a genetic predisposition. That is false. Or is that true?
True. It's only that type 2 has more genetic predisposition than type 1, but both have genetic predisposition.
Okay, the one with more genetic predisposition, is it type 2 or type 1?
Wait.
It's type 1 actually.
Sorry for that.
Thank you for that. So glycated hemoglobin is also, we know it as an indicator of glycemic control. So B is actually the best answer for that. Okay, we can proceed to the next question unless someone has a query.
My question. Is metformin the only one that doesn't cause weight gain?
Okay, personally, I'd say no, but like to hear someone else's views, because the DPP4 inhibitors are used for weight loss. I don't think they'd be used for weight loss if they cause weight gain, but anyway, I don't know.
I thought DPP4 also causes weight gain.
Oh.
Yeah, I think bigonads are the only ones that cause weight loss. I thought so though. Not sure.
Okay, I'm not so sure about it, so maybe someone else can confirm it for us. Yeah, so the GLP-1 agonists, the Kinawegovy and the sitagliptin, basically. So yeah, so Tur, I hope your question is answered. Okay, so on to question 124. The main adverse effects of inhaled corticosteroids is A, oral candidiasis, B, bone marrow suppression, peptic ulcer disease, and D, glaucoma. Yeah, so True says oral candidiasis. That is very correct. And that is why for patients taking inhaled corticosteroids, they're usually advised to rinse the mouth with water after taking the medication, basically, the aerosol medication. So 123, captopril-induced cough is due to A, accumulation of bradykinin, 2, breakdown of angiotensin 2, suppressed production of aldosterone, and hypotension. So Nugal says that is accumulation of bradykinin. And yeah, we know that to be correct. So the S inhibitors actually inhibits bradykinin, and that results in the dry cough. That is usually very common in some of these patients. And I hear it's usually more common in females than males. Yeah, but it's usually due to the accumulation of bradykinin. So if a patient develops that, you can, I think, switch their medication to the angiotensin 1 receptor blockers, because they basically just inhibit the receptors and won't cause and won't result in the cough. Yeah, so Nugal also adds that DPP4 inhibitors cause accumulation of bradykinin, leading to cough and nasopharyngitis. So I think we had come across that, and yeah, so thank you for that addition. Okay, so we are here. Question 122. Allopurinol A causes hyperuricemia. B inhibits xanthine oxidase. C is an non-steroidal anti-inflammatory drug. And D should not be used in cancer patients. So Dr. Gaius says B inhibits xanthine oxidase. So that is actually true. So what do we usually use allopurinol for? Yeah, we use it for gout. Do you also use it for hyperuricemia? It's the same thing, right? So, but here, I think Guy said for a patient with hyperuricemia, you give first the NSAIDs, probenecid. Is that what you said? Then the allopurinol will follow. I hope I'm getting it correct. I don't know. Guys.
Yeah, what's up?
Yeah, so how did you say we manage hyperuricemia, basically? Or gout? Let me just talk about gout.
Okay. If it's asymptomatic hyperuricemia, no pharmacological therapy needed. But now in the case of gout, the acute one, you want to start on an NSAID. You know, they're usually in intense pain. So you can start on an NSAID and allopurinol on the same day. The only thing you shouldn't do is start on allopurinol alone. It will worsen the gout. So NSAID plus allopurinol, or if you want a paper, NSAID alone, give it 2 weeks, allopurinol start allopurinols.
Do you use this Febuxostat stats for the same indication?
Yeah. It's more selective even.
So you know that you're not seeing ecumenical content. Okay, thank you for that. So question 21. A patient suffering from asthma, coronary heart disease, and
Excuse me.
Uh-huh.
I think we have a request. We go through gout and hyperuricemia once. Before we go to the next question, please.
Okay. Okay. Does anyone want to give us a summary again? I think Gus has given a summary, but maybe he can.
Okay.
Yeah.
So gout, we all know what gout is, right? It's that it's characterized by that hyperuricemia, the uric acid, the salt, they will be deposited in the joints, and the most affected area, or rather the most affected, let me just say, we know the big toe is usually the most affected site, or where it will usually manifest. Risk factors is just the usual things like obesity. Then for gout specifically, we know this red meat, a lot of red meat, a lot of beer, things that contain this high concentration of purines, such will lead to purine breakdown, leads to production of the uric acid, right? Uric acid is a breakdown product of purine metabolism. Hence why the meat will not be a good thing for people with gout. Also, the other thing is in chemotherapy. Someone here mentioned about tumor lysis syndrome. Yeah, because we know when you're giving chemo, now it will be for specific types of cancer, but generally when you're giving chemotherapy, you're essentially killing a lot of cancer cells, or a lot of cells. These cells, their DNA will be broken down. So we will be breaking down a lot of purines. When we break them down, we can produce a lot of uric acid, which can lead to some adverse effects. We know things such as uric acid stones. So we give allopurinol as a you can see a cancer patient being given allopurinol to prevent stuff like that. Yeah. So about I think we've mentioned the risk factors, but other drugs can also cause these things, such as pyrazinamide, stuff such as ethambutol, the thiazide, and loop diuretics. I believe low dose aspirin can also cause hyperuricemia. And management acutely, you want to manage the pain. These people are usually in so much pain. So an NSAID will be your first go-to, right? NSAID, if you can't give an NSAID, there's this one called colchicine. And if it's too bad, you can always add a steroid, a glucocorticoid. Well, for chronically, to reduce the serum uric acid levels, we want to give allopurinol, will be the first line. Second line, or rather, if you can't give allopurinol, there's the probenecid, there's the sulfenpyrazone. But usually allopurinol, I see most patients taking allopurinol having no complaints. Just one thing to know about allopurinol, always advise the patient to take it with food. And it can cause Stevens-Johnson syndrome. It's one of the drugs that commonly causes Stevens-Johnson syndrome. So a patient starts complaining of a rash while on allopurinol, you need to watch out for the same. Yeah, that's I welcome someone else to add onto that.
Thank you, Doc. That is a very elaborative and detailed summary. Thank you. So if there is no other query, I think we can move on to the next question. Okay, so the next question. Patients suffering from asthma, coronary heart disease, and asthma should not use A, salbutamol, B, atenolol, C, omeprazole, and D, ramipril. So you give the answer and the reason for that. B. So reason for your answer. Okay, in short, okay, we know atenolol is an non-selective beta blocker. So basically, that means it will inhibit both beta 1 and beta 2 receptors. So the inhibition of the beta 2 receptors are going to basically worsen the vasoconstriction if they occur, or maybe even trigger them. So,
Excuse me, Sam. Oh, yeah. As guys have said, I think atenolol is selective for beta 1, so it's not contraindicated in asthma.
okay, so what would be the reason for that?
Maybe the CHD is the hint.
Personally, I was thinking atenolol because it's the best answer.
Hasna, could you come up again? I didn't get you well.
Oh, atenolol is beta 1 selective. So you could use it in a patient with asthma who has heart failure, right? Oh, so atenolol is not contraindicated in asthma is what I'm saying.
Okay.
But I think it's contraindicated in CHD, so it's the answer. Oh, you are saying atenolol is non-selective, so we're saying atenolol is selective for beta 1.
Okay. So you said the reason why it's contraindicated is because it's contraindicated in coronary heart disease. Hasna. Okay. So
Yes, but atenolol is the right answer.
but why is it the right answer?
Because it's contraindicated in it's a patient with coronary heart disease cannot use atenolol.
Okay. Thank you for that. So, okay, are there any other drugs that would be contraindicated in such a patient? The patients that we have in question 121, or any drugs that won't be advised for use in patients? Okay, and there's a question to give an explanation as to why we're having atenolol being contraindicated in the coronary heart disease. as yeah. So heroin. Oh, yeah. Okay, yeah, heroin. I think we can add NSAIDs there because of the asthma, right? And someone is
Excuse me?
asking that. Yeah.
Excuse?
Mhm.
But aren't beta blockers used in coronary heart disease?
I actually thought the same. So I guess something.
Cardiac oxygen
Someone can give
demand.
us
So
explanation.
in this case, I think I'll go with the ramipril because it can cause a cough and the cough may worsen the asthma. Okay, I'm not really so sure.
Mhm.
But beta blockers are used in coronary heart disease, so I don't think there is a contraindication.
I
Okay.
think the catch here is the asthma. You cannot give the beta blockers in asthma, they will cause bronchoconstriction. So it will worsen the asthma. So the other thing is atenolol.
You can actually give.
Cardioselective.
So atenolol is
Selective beta blocker. Or maybe you can't use 2 beta blockers at a go. Maybe. That
Selective.
And someone was asking, is the selectivity of this beta blocker drugs dose dependent? I have a feeling they are in some cases, not in all cases. Okay, I don't know.
No, I don't agree with what you're saying because it's written there are some conditions in which beta blockers are not recommended. This includes uncontrolled heart failure, hypertension, as well as asthma.
But for
So,
asthma, non-specific, right? So non-selective.
Ati?
For asthma, we usually say the non-selective ones. For the selective ones, you can use them.
Yeah, but it's fine. But the most appropriate answer would be atenolol because literally it's contraindicated, especially because of the asthma. That I feel like that is what would qualify it to be the answer.
Yeah, we actually agree the answer is
It's
atenolol.
cardioselective.
Reason.
Because there was someone who had said they disagreed.
No, they didn't. Okay, okay. So yeah, there's that. So we were just trying to find a reason.
Alternatively,
Uh-huh.
maybe someone can give us just a brief overview of how we manage coronary heart disease, because I think beta blockers, especially cardioselective, they're used for coronary heart disease to decrease myocardial oxygen demand. So maybe we can get an overview of coronary heart disease management, and then we'll see the best option.
Actually, see, you used a very technical term. You seem to be having some good knowledge on that, so you can take us through if you don't mind.
Unless I just check out on how we manage coronary heart disease, just a minute. Or if something they can share, and then we go through the same.
Yes.
Yeah, while he takes the minute, there's someone in my DM. I won't mention her name. She's asked for confidentiality.
Okay.
Anyway, her thoughts is that omeprazole is the answer because the patient is having asthma and coronary heart disease. There's no mention of gastroesophageal reflux. There's no mention of gastritis. Why is this patient on taking omeprazole? So there's that thought.
Okay, okay.
Yeah.
So
When they get acidity, they use omeprazole.
If or when.
maybe they
When
even
they get sick.
coronary artery disease or the coronary heart disease. So they would actually be on the omeprazole if they're hospitalized. Okay, do we move on to a different question as we move on to a different question as someone tries to find ama we just wait kidogo. Okay, so something I learned today nilikuwa nataka niwashainie kidogo. Acha niwashainie kidogo. So nilikuwa nimeeleza other drugs that can be contraindicated in this. So Gas alisema heroin. Yeah, hiyo siko sure nayo, but yenye niko sure nayo ni NSAIDs. Like someone mentioned aspirin. So I noted there are some drugs that are actually indicated. If a patient is asthmatic and they happen to get that, or to be given the NSAID, and they get an exacerbation due to that, then there's a drug, an anti-asthmatic drug that you can give. So acha ni shine hapa kidogo. Hiyo walisema ni the leukotriene inhibitors, montelukast, zafirlukast. Yeah, they're actually indicated for aspirin-induced asthma. So yeah, content iko. Yeah. Guys, kwani siwezi shine? Okay. Haya, sawa. Okay. Okay, so maybe I can move on to the next question. Then the person that is going to look into the drugs that can be used for management of coronary artery disease, coronary heart disease. They'll give us that overview once they're done. So wakipata the info, tuambie tu, then we will give them the time to continue. Yeah, so for question 120, which of the following is a H2 receptor antagonist? So A, esomeprazole, B, ranitidine, C, misoprostol, and D, omeprazole. Liz, unaweza tuambia hiyo? Nimekuona ukismile hapo kwa chat box.
B needs ulikuwa na content, so yeah, ni B, ranitidine.
Yeah, ranitidine. So any information, any further information that we need to know? So esomeprazole, okay, hizo ni vitu rahisi, si ndio? Ni okay, anything we might need to know kwa hizi. Okay, let me just ask this question then as we move forward. So what are the drugs which are usually considered mucoprotective? The drugs used in GAD or H. pylori, which are considered mucoprotective. I think they're usually 3. Yeah, misoprostol is one of them. Yeah, so miso, sucralfate, and bismuth salicylate. Yeah, so there is some information that ranitidine was discontinued due to NDMA. Okay, what is NDMA? Ni receptor. And no, NMDA. No, what is NDMS for Asman Abdul Malik? Oh, nice. Oh, okay. So this is it's not an anti-cancer, it's a carcinogen. Yeah, the nitrosomethyl. Okay, yeah, whatever. Oh, it's usually not NDMA. Oh, yeah, okay, yeah, it is. Yeah. Thank you for that. NMDA for glutamate. Thank you. Okay, so question 119. Hypokalemia may be precipitated by all the following except furosemide, hydrochlorothiazide, bumetanide, and spironolactone. Of course, that is obvious, spironolactone. So that is a potassium-sparing diuretic. So for this potassium-sparing diuretic, they're usually 4 of them: spironolactone, eplerenone, what is the other one? Amiodarone. Is it amiodarone? And tramterine, amiloride. Yeah. So Which ones are usually the receptor antagonists? Because I think they have different mechanisms of action. So spironolactone and amiloride, do they inhibit aldosterone directly or the receptor?
Spironolactone is for the receptor. Amiloride and triamterene are for the sodium chloride channel in the collecting tubule. Oh yeah, the ENaC.
ENaC, yeah. Yeah, thank you. Okay. So eplerenone, I think, is under the same spironolactone. They have the same mechanism of action. So there's usually this acronym SEAT, S-E-A-T. So S and E, I think, have the same mode of action. A and T, the same mode of action. The ENaC, as was mentioned. In exam number gani hiyo tunatafuta? Okay, there's someone who is trying to find some information for us. Alipata on management of coronary heart disease.
Yeah.
Thank you.
So in management of coronary heart disease, we can use a combination of drugs. So intervention two is drugs, and then my dosages you can check at your own time. So the first drug you can use is cholesterol drugs. These are used to lower bad cholesterol and reduce plaque buildup. And these just include the statins, fibrates, and bile acid sequestrants. You can also use aspirin. It acts as a blood thinner, so it prevents formation of blood clots. And then beta blockers are used, and these drugs lower the heart rate, so they also lower blood pressure. And I've also seen that beta blockers, as aforementioned, as someone has already mentioned, their selectivity is dose dependent, so that even beta-1 blockers, beta-1 selective agents may induce bronchospasm in higher doses. So also as a relative contraindication of beta blockers is asthma, bronchospastic disease, and severe depression. So I think the correct answer will still remain to be atenolol. But I've seen that in the absence of any contraindications, beta blockers are the preferred initial therapy to prevent symptoms of angina. This because they have potential cardioprotective effects. So they decrease the heart rate and force of left ventricular contraction and also lower BP. So other drugs for management of coronary heart disease, we have calcium channel blockers. So calcium channel blockers are recommended, especially when beta blockers are contraindicated or are not tolerated. Apart from calcium channel blockers, also you can use calcium channel blockers and beta blockers in combination, such that they improve symptoms. They act synergistically better than either drug used alone. So an example is a combination of a beta blocker with either verapamil or diltiazem. They're used in extreme conditions. Apart from calcium channel blockers, we have long-acting nitrates, and we have both oral and transdermal formulations, and long-acting. So adverse effects of long-acting nitrates that you should note: we have postural hypotension, we have dizziness, we have flushing and headache. For the headache, you can give acetaminophen. So the long-acting nitrate formulations, kuna nitroglycerin extended release capsules, kuna isosorbide dinitrite tablets, etc. So you can also use ranolazine, and I think this is used for special population in variant angina. In variant angina, you can use ranolazine. So basically, that was it. So the best answer would still be the one contraindicated is atenolol. Yeah, that's it. Unless anyone has anything to add.
Thank you for that. So yeah, so Baraz is actually a class rep. Yeah, mpatie heshima. So yeah, naona guess
Hata hizo notes.
We mzee, wacha mambo.
yeah, so I guess I may add something for group in form of a question, but hajeka question mark. Doc, punctuate your statements, please. Yeah, and there's a question. So amesema, I thought beta blockers and dihydropyridine calcium channel blockers are contraindicated due to the risk of second or third degree Has block. I think that is true, especially for the CCBs. But I think in vasospastic angina, they usually use for the CCBs especially. So there's usually a risk of this. So, okay, so this is subject to further investigation. So maybe someone will confirm for us as we move. Spend a lot of time on that. So someone can also look into that. Yeah, and send information into the group. I think that will be very useful. Thank you. So question 118, unless someone has something to say or add or subtract, any omission or commission. Okay. So an example of a selective serotonin reuptake inhibitor is, so we have fluvoxamine, amitriptyline, nortriptyline, and lithium. Yeah, Heral says, and that is correct. Actually, agree with Heral. Heral can't be wrong. So the other drugs, amitriptyline or triptyline, those are TCS, if I'm not wrong. Content yangu haijafika hapo sana, but yeah, lithium is usually used in bipolar. Has an advantage of mood stabilization, and yeah, basically that and valproic acid or valproate. So, okay, can someone give us examples of other examples of serotonin reuptake inhibitors and the norepinephrine and yeah, norepinephrine and serotonin reuptake inhibitors? Yeah, Heral also added that lithium is a sodium channel blocker. Oh, she's asking, is lithium a sodium channel blocker? Guys with content. Less than 7 days to exam, guys. Is lithium a sodium channel blocker? So Anita has sent a very a very good summary in the group. Yeah, so I think you can all go back and have a look at that in your own time. So yeah, and Tour adds lithium inhibits the function of voltage-dependent sodium channels and catecholamine secretion, which is independent of glycogen synthesis kinase 3 in the adrenal chromaffin cells, which, so that has been referenced from Google. Thank you for that, Tour. Yeah, so I think that is answered. It's actually a sodium channel blocker, but for the voltage gated sodium channels. Okay, so the following indications are indications of carbamazepine, except A, trigeminal neuralgia, B, epilepsy, C, manic depressive psychosis, and D, arrhythmias. Yeah, Lydia says arrhythmias. That is correct. So any other drugs that can be used for trigeminal neuralgia? Anyone? Other than carbamazepine? Okay, acha niwashainie tena basi. So there are these drugs, but you can go confirm. The pregabalins, the gabapentinoids. I think especially pregabalin can be used for that. So is carbamazepine broad spectrum anti-seizure drug, or is it narrow spectrum? It's a broad spectrum. So Shrina adds that it's actually a mood stabilizer as well. So I didn't have that information. So yeah, you're allowed to add that to your notes. Yeah, Tour has also shared some other information. Thank you for that. I think we can move to the next question. Or maybe before we do that, we can briefly look into arrhythmias kidogo too, because okay, I'm not really sure if we've looked into them extensively, but briefly too. And the classes used, the antiarrhythmic classes, or the antiarrhythmic drugs, the classes of antiarrhythmic drugs that we have, a couple of examples, and especially for the class 1, the action, like what is prolonged, what is not. Yeah, carbamazepine has an side effect of causing aplastic anemia. Yeah. Thank you, Shrina. Liz. Liz, it's a time to shine.
Okay, so I don't remember what's actually specifically, but we have like 4 classes. We have class 1, class 2, class 3, and class 4. Class 1, I think it's the sodium channel. This is the sodium channel blockage. Class 2, beta blockers. Class 3, potassium channel blockers. Class 4, it's the calcium channels. And an example here is we use the non-dihydropyrimidine. Yeah, the diltiazem and verapamil. Beta blockers, you know the examples. And then class 1 is further subdivided into 1A, 1B, 1C. I can't remember the specific examples there. Class 3, the potassium channel blockers. An example is amiloride and a a beta blocker that is under that one. Yeah, that's all that.
Nice. So yeah, Sheena, I may add some information to the group, so you can actually go have a look at it. So I think it should be important to know what is usually prolonged, etc. Like this things, what is usually shortened, which phase is shortened. Yeah, I think that will be useful for you guys. But just to summarize from what Sheena has sent in the group, for the class 1A, we usually have they usually slow phase 0 depolarization in ventricular muscle fibers. For class 1B, they shorten phase 3 repolarization in ventricular muscle fibers. And class 1C, they usually cause a marked slowdown in phase 0 depolarization in the ventricular muscles. Yeah, so I feel like that gives you a very good general overview of that. Like, yeah, so you can go have a look at them, the side effects of the drugs used, etc. So I think we can move to the next question. Thank you for the contributions for that question. Sheena, please. Thank you. Okay, so question 116. Concurrent administration of rifampicin and warfarin may lead to A, enhanced activity of rifampicin, B, reduced pharmacologic effect of warfarin, C, severe allergic reaction, and D, neutralization of the effects of both drugs. Sorry. Anita says B. So B says a reduction in the pharmacologic effect of warfarin. So as we know, rifampicin is an enzyme inducer. So it's going to induce the cytochrome enzymes to basically break down warfarin or metabolize warfarin at a faster rate. So you're going to reduce the effects of warfarin in this case. Yeah, so that is correct. So an example, or rather examples and mnemonics of getting to know the other enzyme inducers and inhibitors as well. Yeah, you guys have content. You can mention these things in the MBO as we go. Guys, can you hear me? Okay. So, but discussion added, griseofulvin, phenobarbital, phenytoin. Yeah. So for the inhibitors, we have azoles, the ketoconazole being one of the potent ones. So let me shine on something else again. So in the morning, we discussed we briefly discussed on the HIV medication drugs. So we have these medication drugs usually referred to as the protease inhibitors. So there are some of them which are usually given as combinations, and they usually take advantage of one of these effects of enzyme induction and basically enzyme inhibition. So for the protease inhibitors, which ones do you know that are usually given together? As we move BMBO to, guys. Yeah, so gas added lopinavir ritonavir. So usually it has a brand name. There's something called Caletra. So and in this case, they usually give, ritonavir has some activity, but it's usually given to enhance the activity of lopinavir by basically, it's going to be metabolized in place of lopinavir. So you're going to have lopinavir being in the system for a much longer duration of time. So there's another one. Which one is given with atanazavir? Okay, so we have the other one called, it's usually called cobicistat. So information yangu mwende verify tafadhali. So also, yeah, there's atanazavir, ritonavir as well. There's also cobicistat, which can usually be given. They usually consider it a protease inhibitor, but it has no activity. But it's given to help boost the levels of atazanavir in some cases. Okay, so yeah, for question 16, Shin, I think you'll mark B. Then question 115. The most common cause of emphysema is A, tobacco smoke, B, stress, C, alcohol consumption, and D, silicosis. Yeah, so tobacco smoke is actually the answer for that. So silicosis, I think you know, from basically inhalation of silicon, that is in miners and other people, C miners while they were under 18, miners when wanafanya mining of silicon, and basically those people that work in such factories. Alcohol consumption, in this case, alcohol atutai blame this time. This time alcohol is innocent. Stress, not really, not as much. So tobacco is actually our answer. So try to waste a lot of time over there. Oh, mi sifanyi exam huko, nafanyia exam Nakuru. So sitakuwa huko. Exam namba yangu itasaidia sasa. Anyway, so question 114. Hematemesis may be caused by all the folic diseases except. So peptic ulcer disease, Mallory waste tear, tuberculosis, and cancer of the stomach. Okay, someone says tuberculosis. That is correct. Na nimerealize kuna watu 43 hapa, but naona watu wana contribute ni kama watu 4 5. Like I feel like it's actually really more engaging if we get to hear or get more information from a lot of you guys. It makes the revision even more, yeah, more engaging and more.
They think fast, they are thinking faster than us, so it's okay.
Okay. So yeah, the answer is tuberculosis. So cancer of the stomach, obviously, you know that will cause peptic ulcer disease. I've actually seen that. Mallory waste tear, I haven't heard of that my whole life. So you can have a look at it. So these people say it's actually bleeding caused by a tear in the upper lining, a tear in the upper lining of the stomach. Yeah, so yeah, some new information nimepata leo. Nice. So tremors are a side effect of what? Propranolol, salbutamol, atenolol, captopril.
Salbutamol.
Salbutamol, yeah.
Salbutamol.
So salbutamol is correct. The beta agonists used in asthma, they usually have that side effect.
And it's actually in overdose, if I'm not wrong. In overdose, they will stimulate beta 1 receptor. Yes.
Nice.
The tremors
So
are dose dependent.
yeah.
Same thing.
Okay, something else. Yeah, I think it's the same thing, Nasema. So on salbutamol, I think okay, hiyo content imepotea. Oh, yeah, nilikuwa nataka kusema salbutamol is usually subject to tachyphylaxis, right? and they're usually not recommended to be used as monotherapy. And I think that is why the guidelines will recommend you combine them with the corticosteroid. So I've seen a lot of questions on tachyphylaxis. Yeah, so if you see that, you can always remember salbutamol. Gas amenibak. Nice. So, okay, so question 112. The central cyanosis may be caused by pneumonia, gastritis, hypertension, and migraines. I think that is self-explanatory, pneumonia, because we'll basically we'll have poor ventilation because of the damage to the lungs. So gastritis is basically just bleeding and all other pains in the stomach, etc. So hypertension, not really. Migraines, not really. Okay, so 111 rather. Which of the following is not a feature of acute renal failure? So edema, elevated blood creatinine level, hypokalemia, and elevated blood urea nitrogen. Which is not a feature of renal failure? Okay. Ona will go back to your question. We can answer this, then go back to your question. Yeah, Brenda says the answer for that question is C, and should actually be very correct. So I think yesterday, we said potassium sparing, that is diuretics such as spironolactone, are actually contraindicated in acute renal failure, and that is because of hyperkalemia. So hypokalemia is actually our answer in this particular case. So someone was asking, Honor, that is, it's Honor, right? I hope. He or she was asking, what is central cyanosis? Anyone? Okay, personally, I just thought cyanosis is usually this particular condition where we'll describe a patient being bluish, and basically it's because of poor perfusion or poor ventilation in the body. So central cyanosis, I think could actually occur due to they were asking, but he or she is still gender neutral. Okay, asante lakini. Yeah, thank you. They were asking. Okay, so so yeah, basically just poor perfusion. So by the fact that they're saying central perfusion, I think it should actually be due to a defect in the central nervous system, basically leading to inadequate ventilation. Yeah. So ABC said inadequate oxygenated blood. Is there a cause for it for central cyanosis? Is there any relation with the CNS? It's just what it is. It is what it is. Okay. So I hope, Ona, you've been answered. So we can move on to question 110 as we mark question 111 as C. So Pablo, I hope not Pablo, Escobar is saying it is caused by a serious heart, lung, and blood disorder. Nice. So that is actually in relation to central cyanosis. Okay, so which of the following is a complication of gastric resection or vagotomy? Yeah, vagotomy. Yeah, sijaibisha watu wa shule yangu hapo. So which of the following is a complication? So is it dumping, weight gain, diabetes mellitus, or renal failure? But did you say what dumping was? I think we came across a question. Ilikuwa is about dumping. What was the question? Like tumefanya vitu mingi hadi hata brain imechanga. Nice. You can look at something nani ameadd hapo. Oh yeah. Hii ilikuwa for extended release tablets. Thank you. Yeah, true. Guys. Well, hii brain isianze kunilet down saizi. So which of the following is a complication of vagotomy? So is it dumping? Is it weight gain? Is it diabetes mellitus or renal failure? Hasna goes with A. So okay, so these people hapa walikuwa wamesema dumping is actually the process where ingested foods bypass the stomach very rapidly. Okay, so basically the process by which the ingested foods bypass the stomach very rapidly. So we don't expect weight gain with that because basically you've cut up part of the stomach. So yeah, it actually makes sense as an answer. So yeah, okay. So hypokalemia may be precipitated by all the following except A, hyperaldosteronism, Cushing syndrome. Huh?
Can I add some of other complications?
Oh, nice. That would be amazing. Oh yeah, true. Yeah.
Yeah, internal herniation, dumping syndrome, bile reflux gastritis, and afferent
go
loop
on.
syndromes.
Nice. But there's also a type of anemia that.
Apart from. Okay.
Thank you for that. I think there's also another form of anemia that we might expect in such a patient. And what type of anemia might that be, and what would be the cause for that? Madaktari, changamkeni.
Pernicious.
Yeah, pernicious anemia, which is basically a type of megaloblastic anemia, and that is due to loss of intrinsic factor, which is essential for the absorption of vitamin B12, cobalamin, or cyanocobalamin, as some of you would want to call it. Okay, thank you for that, guys. So hypokalemia may be precipitated by all the following except A, hyperaldosteronism, Cushing syndrome, hypoaldosteronism, and D, vomiting. What is your answer and why? Lydia says C. Lydia, do you mind sharing your reason for going with choice C?
Aldosterone is involved in the regulation of sodium, so it causes loss of potassium, which causes hypokalemia, meaning in hypoaldosteronism, we'll have hyperkalemia, not hypokalemia.
Yeah, that is very true. So aldosterone usually basically leads to sodium retention. If it leads to sodium retention, then potassium has to be kicked out because of that. So basically, in hypoaldosteronism, we have insufficient aldosterone hormones. These glucocorticoid hormones being released. And for that reason, then we expect aldosterone to be low. So we expect lower sodium retention and basically more of potassium retention instead. Thank you for that. So I'd like to ask a few questions over here, a few questions on vomiting. So vomiting usually causes loss of electrolytes from the body. So what does it usually cause? Is it metabolic alkalosis or metabolic acidosis? Yeah, Abigail also added something that's vomiting usually leads to loss of electrolytes, and potassium usually is one of those lost electrolytes. So board discussion says alkalosis. Yeah, so guys, so why would we have alkalosis in this particular case? Is it because we are losing the gastric contents, which are usually acidic? Okay, what is usually the reason for the alkalosis? Someone? Felicia, you could unmute and tell us.
I'm not sure. I actually don't know. Najua too. It's vomiting is alkalosis, diarrhea is acidosis.
Okay, thank you. So I can shine for you guys over here. Usually has some,
It's because it leads to loss of the hydrogen ions, so it will lead to alkalosis.
Okay, that is a good trial. Okay, this is my perspective. This is what I had in mind. It's usually due to the loss of potassium. And the potassium, I think, due to its use in the potassium pump, or its role in the secretion of acid, then it actually leads to the alkalosis. So I don't know if you guys agree with that, but you could go look into it. Yeah, just giving you a heads up. Cushing syndrome, anyone? What is Cushing syndrome? What are some of the drugs that can cause it? Mbio tu, ni kitu ya kumention as we move on. Okay,
Tumor of
so
tumor of the outer part of the adrenal gland.
leading to what?
Cushing syndrome.
Yeah, so it's usually due to the production of it's the overproduction of the glucocorticoid hormones, basically the aldosterone, basically cortisol, all those things will result in this, and that is why I also use prolonged use or chronic use of especially systemic corticosteroids might also lead to this particular disorder. So go look into the symptoms. Yeah, thank you. Okay, so most common cause of pneumonia is Streptococcus aureus, Streptococcus pneumonia, Streptococcus viridans, and Haemophilus influenza. So strep pneumonia, correct. Haemophilus influenza tulisema ina cause nini? Tukienda mbio mbio. Guys, mazi, mnani let down. The 39 people.
Upper respiratory tract infection.
Yeah. So we have pneumonia, it can cause otitis media as well, and bacterial meningitis, very important. So staph usually skin infections, boils, etc. Necrotizing fasciitis, I think, as well as the sore throats. So which of the following cranial nerves is damaged, if damaged, can lead to loss of balance? Is it the 7th, 6th, 8th, or the 9th? Someone says the 8th. So what is the name of the 8th cranial nerve? And so it is the vestibulocochlear nerve. Yeah, basically innervates those regions of the ear. Yeah, the vestibular apparatus, yeah, etc. So there are drugs that usually cause a damage to this nerve. Some drugs used we can start with the drugs specifically used for the management of TB that damage the 8th cranial nerve. Someone, Mbio. the anti-TB drugs that damage the eighth cranial nerve. Yeah, so Gaius amesema the aminoglycosides, basically kina streptomycin, they're usually the second line anti-TB drugs. So they have potential to damage the eighth cranial nerve. So yeah. So what is the seventh cranial nerve, the sixth cranial nerve? Which other cranial nerves can be damaged by drugs? So you can just share that in the group, in the chat box or in the group as well. Cranial nerves and maybe the damage that may be caused by certain drugs to them. I think that you'd have contributed to humanity if you did that. Anyway, question 106. Cunning's sign is used to diagnose what? Peptic ulcer disease, meningitis, pneumonia, and encephalopathy.
Meningitis.
Meningitis. So we usually have another sign. What do you usually call it? And what is Cunning's
UNC.
there before we go to the other sign? Or how is it demonstrated, basically? Yeah, so Doc amesema ni ile ya magoti.
Cunning is on the knee. Oh,
Yeah, so the patient usually
Brunsky is for the neck.
Yeah, Brudinsky sign, right? Usually referred to as stiff neck. So for Cunning's sign, you basically put the patient on a supine position, then you lift one knee. If hiyo mguu ingine itainuka jua, yeah, huyu patient wako amepata hii kitu. So we usually have this triad, the triad for meningitis, the triad symptoms. What are they? Mbio, someone, siki kuitaita watu, lakini sasa you guys are letting me down. Abas, tuambie sign moja, one of those triad signs of meningitis as we move on. Abas, moja tu.
Neck stiffness.
Yeah, kuna neck stiffness.
Altered status, fever. Those are the three signs of meningitis.
Yeah, so we usually have neck stiffness, we have headache, yeah, and photophobia as well. So something to mention. So a lot of meningitis patients usually have very severe headaches. So there's usually something that is recommended for those patients. So what is that remedy that they usually recommend you do? And to what level? Basically to reduce the headaches that they have. Natural rigidity. Okay, so basi, we can move to the next question. So the next question is asking, the clinical features of portal hypertension include all the following, except,
Excuse me.
I see marijuana.
I'm saying you tell us if you know, please.
Okay, so this is something they usually recommend. You do a spinal tap. Basically, just remove a bit of the, what do you call it, the spinal fluid. They usually recommend 10 to 20, because 10 to 20 ml, because if you remove more than that, you also predisposing the patient to more spinal more headaches rather. Yeah, just that. So 105. So the clinical features of portal hypertension includes all the following except. So splenomegaly, ascites, varicose bleeding, and cyanosis. Someone says cyanosis. Is there anyone who has an alternative answer or an alternative truth? Anyone in disagreement? Nice. So usually portal hypertension will have ascites, splenomegaly, and varicose bleeding. So for varicose bleeding, there are some drugs which are usually recommended for the management of varicose bleeding. Mbio mbio as we go. Hata naona moja imewekwa hapo juu. Okay, it's usually not that, but yeah. So how do you usually manage varicose bleeding? Mi nitawapatia answer zangu, lakini zangu si sure. Guys, I know you know. So beta blockers chronically, and you also give telepressin acutely. Yeah, basically, is it drugs? Is it vasopressin? I don't know if they're analogs. What do we call them? Is it desmopressin? Liz said propranolol. Yeah, octreotide I think is also used. It is, right, guys?
Yes.
So is it drug talipressin or desmopressin? What do you call them? What are they called? Are they vasopressin agonists? No, they're not agonists. They're analogs, right? What is the term used to describe them? What is the class rather? They're analogs. Okay, thank you. Nice. So, okay, we can mark D for 105, then move on to 104. Okay, okay, so we have 4 minutes. So maybe you can do this pathophysiology section, then we'll take a break. Ama overstay, hapana, time iko sawa. Oh, but tulianza late, maybe tunaweza, okay. Anyway, sawa tu. So question 104, diabetes insipidus occurs due to the deficiency of what? Vasopressin, glucagon, estrogen, growth hormone. So hiyo ni vitu za high school. That is basically ADH hormone. Diabetes insipidus, we're basically urinating dilute urine, basically. So vasopressin is usually used for, basically forms aquaporins in the distal tubule, which absorbs water. So which of the following is a feature of hyperthyroidism? So A, elevated TSH, decreased T4, and decreased T3. So B, we have decreased TSH, then we have decreased T4, decreased T3, then we have decreased TSH and elevated T4 and T3, or elevated TSH and elevated T3 and T4. So kila mtu amesema C. And since we've sung in unison, I think we don't need to waste any more time over there. Although I do have a few questions hapa hivi kwa hyperthyroidism. So how do you usually manage hyperthyroidism? So usually, okay, wamesema one of the features kwanza ni decreased TSH but elevated T4 and T3. So why do we usually have an elevated T4 and T3 if the TSH is decreased? Okay, acha nasomea hapa wenye walifanya hii kitu walisema it's because of a negative feedback. So usually between T4 and T3, which one is in more quantities and which one is more active? Which one is the active form and which one is usually produced in the larger ratio? So T3 is the active form, right? Triiodothyroxine, and usually produced in the smaller accounts. The ratio of T3 to T4 is usually lower. So for management of hyperthyroidism, so you decrease sympathetic symptoms by giving beta blockers for a short period of time. That is very true. Then chronically, you will give antithyroid drugs, that is methimazole and PTU. So between methimazole and PTU, okay. So PTU is usually more recommended in the later stages of pregnancy, I think. Although niliona somewhere walikuwa nasema methimazole should be given in the first trimester. I don't know if that is the correct term, but in school we used to say to PTU ndio inapeanwa in pregnancy. It's the safer version. So you can also do surgery, basically remove the thyroid gland. Other than that, hypothyroidism, basically you supplement iodine etc. So I wanted to ask the other important question. So we usually have some disorders of thyroid hormones. So there's some disorder we refer to as Hashimoto's disease and the Graves' disease. What is the difference between the two? Yeah, basically just give a summary on that, and then we can move on to the next question. Nice. And Heral has given us a reason as to why we're having lower TSH and elevated T3 and T4. Okay, so ABC is asking, is hypothyroidism Hashimoto? So I myself, I'm not sure. So maybe you can start by defining what is Hashimoto disease. Is it a normal disease? Is it autoimmune? Yeah, then mbio too.
Graves' disease is an autoimmune disease, if I'm not wrong.
Yeah, Graves is usually autoimmune, and usually we have antibodies which resemble the TSH. Yeah, so they basically stimulate the thyroid gland to produce to produce these hormones that we have over here. Yeah, so both are usually autoimmune, like Pablo has shared. But in Hashimoto, we have decreased levels of thyroid hormone. But in Graves' disease, we usually have elevated levels, and usually associated with things like ophthalmia, macho kubwa, like the bulging eyes. There's usually a name to that. Yeah. Okay, Hashimoto is type 2 and Graves is type 3. Nice. So that is some very important content to note over there. Yeah, so I think we mentioned type 3 immune complex, right? So like we said in Graves, we have some antibodies which resemble something. The TSH, exophthalmos swelling. Yeah, so exophthalmos, that is usually basically the eyes look bulged out. Yeah, so PTU is considered the treatment of choice, particularly in the first trimester. The lower possible doses of PTU to maintain maternal euthyroidism should be used. So given the potential for maternal adverse effects, PTU, e.g. hepatotoxicity, patients should be switched from PTU to MMI in the second and third trimesters. Yeah, so thank you for that. Thank you for that, Dr. Gaius. Okay, so 102, polyuria and polydipsia are not associated with DASH. So is it diabetes mellitus, diabetes insipidus, hyperparathyroidism, or hypothyroidism? Polyuria and polydipsia. Yeah, Doc says hypothyroidism. Do you guys agree? Yeah, so they're usually associated with diabetes mellitus, especially during, I think it's diabetic ketoacidosis, right? If I'm giving you the correct information. Information yangu mwende mverify tafadhali. Msiseme ni mimi ndo nilisema. Yeah, so do we need to look at hyperparathyroidism? Would you guys want to mention what is usually expected in terms of calcium and phosphate absorption during hyperparathyroidism? Basically, what is the function of parathyroid hormone? What are the cells that produce parathyroid hormone as we move on? Si bado naweza change center, si ndio? Naweza change. Acha nitatuma email leo. Nitatuma email. So guys, hyperparathyroidism. Which gland rather produces parathyroid hormone? Where is it located? What are the specific cells that produce it? And what is the effect of parathyroid hormone on calcium and phosphate metabolism? Hata ni mute ndio muongee. Okay, so Shrina added that we have the parathyroid gland being the one, it's usually adjacent, I think, to the thyroid gland. And its actions usually are to decrease the phosphate levels, but increase calcium levels. They basically alter the absorption of calcium. So you can basically gauge what happens during hyper and what happens during hypo. Parathyroidism. So yeah, you can just look at that in your own time. Okay, so question 101, I think tunaweza malizia hapo. In as much as we started late, maybe tumalize tu hapo ndo next session kuja mapema. So 101 inauliza elevated aspartate aminotransferase, aspartate aminotransferase and alanine aminotransferase may occur in the due to the administration of the following. Okay. Elevated aspartate aminotransferase and alanine aminotransferase levels may occur following the administration of rifampicin, amoxicillin, ranitidine, ethambutol. Nice. Nightwing ametuambia rifampicin. So rifampicin, we know the anti-TB drugs. Rifampicin and the other three, the other two, I mean. Okay, three. Isoniazid, pyrazinamide. They are known to be very nephrotoxic. And I think pyrazinamide is the most, I'm not sure. But they are very hepatotoxic, guys. So because of that, we expect elevated serum aminotransferase levels. So ethambutol usually causes damage to nerve, the ocular nerve, right? Is it the ocular nerve? Hello?
Gaius, what do you mean pyrazinamide is the worst?
I think he means in hepatotoxicity.
Yeah.
Yeah, so someone ametuambia the red-green color blindness, which is usually reversible once the drug has been withdrawn. Yeah. Okay, so because this is the last question, maybe tunaweza uliza something about the liver enzymes as well. So guys amesema pyrazinamide is the worst. Basically anasema pyrazinamide ndio ina cause the worst hepatitis ama drug induced hepatitis, basically elevation of these drugs. So someone is asking, what of sildenafil? What about sildenafil, doc? I thought you were an expert on that one. Hebu tuambie. Guys, what are you asking about sildenafil? Oh, with regards to color blindness. Okay. Hiyo mi sina content. Hiyo lecturers wetu wakulipa wakutufunza hiyo. Pesa yetu haikutosha. So I don't know, guys, with that information. Does sildenafil cause color blindness? Msa kona experience hapa kona experience. Yeah. So Hennessy it's on a Friday leo. Okay. Hennessy amesema agree that it does cause the color blindness. So that is more information for us, and it also results in sort of allergic cough. Nice. So as we wind up, we know the liver usually has a couple of other serum, a couple of other enzymes which we usually measure, and another one is we usually call it gamma aminotransferase. So what do we usually infer from high levels of that particular enzyme? Yeah, Anita, GGT. So what do we usually infer from high levels of gamma? Is it glutarate transferase? Alcoholism, very correct. So Jesse ametupia some very good information. So this one leads to blue-green. So sildenafil actually leads to blue-green photosensitivity, and that is possibly due to the inhibition of PDE6. Yeah, and it is usually dose related. Thank you for that. INH causes hepatotoxicity due to the metabolite acetohydrazine. Nice. You guys have content. So then someone is asking, between ALT and AST, which one is specific to the liver? Yeah, very good question. Oh, it's called the blue pill. Uongo. Elisha ametudanganya hapo, but yeah. So someone is asking, between ALT and AST, which one is more hepatospecific? I tend to think it's AST, but I could be corrected if I'm wrong. Guys, which one do we consider to be more hepatospecific? ALT. Okay. Nice. So I think we can call it a session up to there. Hope you guys have learned something. Yeah. So it was nice interacting with you guys. Thank you for only to those who contributed. Yeah. The rest are not thanking you. I'm only thanking the people who contributed. Yeah, thank you for that. So I think we can meet in the next session. Have a good evening.